Hi, good evening to everyone. Thank you for joining me. Another one of those interesting clinical discussions, as usual, with Dr. Shankara Chetty. I really appreciate his insights, and I know that everything he brings will be valuable. Now, it's important to note this is a discussion about a question that I keep on getting from people. They keep on asking me about blood transfusions, and I usually try and reassure people that this is not a major issue if you really need blood. And so I'm here to talk to Dr. Shetty about it, hear his thoughts and his some of his clinical experience, and so we can make sense of it. I just want to very quickly, before I start, mention P Pins became a YouTube member. And so we have membership on Vejon Health YouTube. And if you joined, I get to see you. You pop up in my feed. So it's an advantage if you want to get any comments or anything done. So please consider joining the YouTube membership. But let's get straight into Dr. Shetty. How are you, Shankara?
I'm fine, Philip. I hope you're doing well as well.
Excellent, excellent. So let's get straight into our clinical question. So, as usual, this is a clinical discussion. We are looking at some of the experiences Dr. Shetty has. He always has great insights. We are talking now about blood transfusion and the fact that a lot of people are very anxious about blood transfusions if they are unvaccinated. I don't seem to hear that concern too much from the vaccinated cohort. Do you come across that as well?
Yes, I do, Philip. A few years back, there was a baby in New Zealand, a newborn who needed a blood transfusion for an urgent cardiac operation, and the parents were willing to donate, which was allowed previously by the blood services. But suddenly, for some reason, you remember at that time we had the lockdowns and all the other issues that we were dealing with in those countries like New Zealand and Australia, and they prevented the parents from donating. There was an outcry. I did address a crowd of demonstrators at that meeting, but the baby was forcibly taken from the parents and operated upon without their consent. So this thing with blood transfusions and the concern about not looking at the vaccination status of the person donating the blood has been there for a long time, and now we're getting to see the effects of that lack of screening.
Yeah, it's just an important point. And just so that people have an idea as to what we're talking about, I've got here something. I had to quickly do this, so forgive me. This is just from Basic Medical Key, fastest basic medical insight engine. And so this guy, Turner, has broken down, and I've got this here, the essential principles of blood transfusions. So they test for a number of things: HIV, Hep B, Hep C, HTLV, syphilis, the ABORH compatibility, as well as other antibodies. They then take that blood and then they will filter it oftentimes to red cells. They take off the platelets and then they take off the plasma. And so when most people, certainly in the UK, when you're getting blood cells, it's oftentimes packed cells, red cells. And then if you need fresh frozen plasma or plasma for anything else, you would give them that separately, or platelets. Important to note that you also can have whole blood where it isn't separated, but it depends on where you are in the world as to whether or not you have access to that. So that's an important point, Shankara, the breakdown of all the blood and the testing that has been done. And blood transfusion services would say their standards are quite rigorous. Why should they change around the COVID pandemic?
I think, Philip, we've seen the coagulation problems. It's accepted worldwide now that there's coagulation issues, immunologic issues that need to be addressed. And we know that the technology that was used with the vaccine uh, gave us very variable results. So we put in a messenger RNA for someone to make spike protein. But unlike with other medications where dosage is very closely regulated, a fit, young, healthy cell that is highly active will make a lot more spike protein from the same amount of messenger RNA than would an aged, inactive cell. So the amount of spike protein could never be quantified. And we're going to find this in blood. We're also going to find antibody levels, like we found excessively high antibody levels in those that were highly vaccinated. We're going to find this excess of antibody showing up in blood transfusions. Now, these need to be quantified so that we can be aware of any issues and how to address those issues. We are seeing those issues, Philip. I've had a lot of colleagues of mine report clotting events post operatively that they haven't seen before in patients that they're operating on. Uh, so clearly, clotting is becoming an issue in the medical fraternity. They're becoming aware of that as an issue. And I've seen patients with microvascular coagulopathies that I've treated successfully. So, yes, I think the screening needs to be there and intensified into antibodies and spike protein levels, but also to draw correlation between these events that we see and any blood group specificity and those kind of things.
Yeah, I'm going to show you something here. So this is a preprint, just in case anybody is watching, and it's on the line that you're saying concerns regarding transfusions of blood products derived from genetic vaccine recipients and proposals for specific measures. It's interesting. It was posted in March of 2024 and it's Japanese. So meaning that the authors are all from Japan. It's not yet peer reviewed, as I said. It here is where is this? Oh, I can't pronounce this. Asahikawa, Tokyo. Tokyo is easier, but this is where they are all from. What I wanted to draw down to is that in the paper they mentioned some of their concerns. One, spike protein contamination, contamination with amyloid aggregates and microthrombi, events attributable to decreased donor immune system and immune abnormalities, including the IgG4. They mention lipid nanoparticles and contamination with aggregated red cells and platelets, and as well memory B cells producing IgG4. So they are raising quite a number of similar concerns, as you have said, Shankara. Um, are they overreacting though? So I can imagine that there's a cohort of people, primarily from the scientific community, saying, "Come on, this is just ridiculous. This is just people just grabbing onto anything and making a big deal out of it." Thoughts?
Philip, we're seeing something new and unexpected. As the medical fraternity, we've come to be able to practice our trade with quite a high level of safety. So when a patient unexpectedly demises in your hands, then I expect a level of outrage and to try and figure out why that is happening. So all those colleagues of mine out there who are seeing these strange and wonderful things happening that never happened before, it dictates at least a level of curiosity to figure out what has changed. So these deaths we talk about, these injuries we talk about, they are not the usual.
Mhm.
So being unusual, it dictates further understanding.
So when we think about it, Shankara, from a real world perspective, have you come across anything that you think could be relevant in terms of, now this is the real clinical thing, anything you've come across in terms of cases that could arguably support this kind of thinking?
Yeah, Philip, I think you see, like I said, the vaccine itself being a messenger RNA delivered production facility, you can give a patient one vaccine and he'll produce a ton of spike protein. And you can give another patient five vaccines and 10 boosters and they make no spike protein at all, right? So human physiology is that way. So spike protein can't be quantified as dosage. So we have this first problem that's there. So when you look at the vaccines itself, each vaccine has this variability. But then we had different vaccines. We had the AstraZeneca, we had the Johnson and Johnson, we had the Pfizer vaccine, and all of them had their little nuances to them as well. If you remember, the AstraZeneca showed up with idiopathic thrombocytopenic purpura and other issues. So it depends on the vaccine. It depends on the patient's reaction to the vaccine. We found correlation between early site of vaccination side effect to long-term injury. Those that had no side effects at all were at less risk of showing up in injury. So all these things come into play. Now, I've had a patient recently, a 40-something-year-old female, who I've never seen before. A husband is a patient of mine, and she presented to me with a sudden enlargement over a 3-day period of area around her neck, and she was having slight difficulty swallowing. And so she came to me. Clearly, there was a swelling around her neck, and on observation, it was a diffuse swelling of her thyroid gland. Now, over a 4-day period, if your thyroid gland swells that drastically, it's definitely under attack. So I immediately did a thyroid function test, thyroid antibodies, and sent her for a thyroid scan, and questioned her history behind how it got to that point. Of course, I was suspecting an autoimmune attack on the thyroid gland. So the vaccination status of the patient becomes quite relevant, and drawing timelines and seeing whether this might be a contributing factor. And I'd found that in 2021, she had taken 2 Johnson & Johnson vaccines. When I asked the history of any side effects, there were absolutely none. I went even back to ask on the day of injection, did she have any side effects at the site of injection? And she said none at all with the two. And she'd been well ever since. In January this year, she started feeling a bit tired, fatigued, and I saw a practitioner who found that she was anemic, a hemoglobin level of 6.3. So they decided to admit her and transfuse her 4 pints of blood. Now, in doing that, she felt a lot better initially, but now I see her with this thyroid problem. And so I had to question further to see whether those 4 pints of blood might have made any difference to the outcome of the sudden autoimmune attack on a thyroid gland. And of course, we know the side effects of the vaccine can be divided into very specific categories. Autoimmunity, so we see a lot of allergic symptoms, that kind of thing. Coagulopathies, we see that happening. And of course, gut dysbiosis and toxicity from that's just from vaccination. We're not talking about infection, chronic, repeated Omicron infection. And so I questioned those areas to figure out, is there something that's changed? And what I discovered was that from the time of the transfusion, she was previously a perfectly healthy person with no real issues. She had developed a sinusitis that would not go away. She could not walk as far and felt fatigued. She got breathless quite often, similar to asthma. She had, on quite a few occasions, a sudden swelling of the tip of her fingers, a single digit. It would be swollen, red, and excruciatingly tender for a day or two and would spontaneously just subside. Microvascular coagulopathy comes to mind when I see a symptom like that. And of course, she developed small joint arthritis, where when she got up in the morning, her hands were all very stiff. And of course, we questioned all those symptoms. With her age, we even went through her menstrual history to rule out menopause, all those kind of things. And her thyroid antibodies came back sky high. The scan showed a diffuse multinodular enlargement of the thyroid gland with varying nodular sizes. Excuse me. So I cannot exclude the transfusion as a trigger for some of these events that she has, because she had none of them before that transfusion.
Oh, let me just pause there a second. I can imagine people listening. So, if anybody is clinical, they will say, well, she must have had an issue before the transfusion for her to get anemic, but we don't quite know what that was occurring prior to her being transfused. So theoretically, she could have had an autoimmune hemolytic anemia, but I'm suspecting they would have picked that up if
Yeah.
they were investigating in a young person, getting anemia. They would probably have screened her for everything and then managed it. And it didn't sound as though they had any concerns after they gave her the blood.
Yeah.
So she didn't have any follow up. So all of that indicates it could have been something very simple like an iron deficiency anemia. So, all right, so let's explore the possibility. When did her symptoms, did she start to say that the symptoms start to get worse?
But Philip, you see, it's the first time I've seen her, and she's been experiencing all these new symptoms. It started with a sinusitis, allergic kind of condition, and then it progressed to arthropathy, and interspersed with that, these digital painful swellings that lasted a day or two. Uh, it would wax and wane. There were some times where she felt perfectly fine, things had everything had settled, and then she'd go back to feeling that way. But in questioning her and trying to get a time frame, it suddenly dawned upon her that all these symptoms had started since she'd been in a hospital for that transfusion. She brought that to my attention. That prior
And it's not
to
chance that she didn't have, say, COVID at the time when she went into hospital?
Well, it was just for the day, Philip, and I usually, with every patient, when I find these kind of symptoms, if not too long ago, I always inquire whether it was preceded by a flu-like illness to see that there wasn't anything infective that could have triggered it. We do see that in vaccinated patients, that they're perfectly fine, and then they have a very mild infection that triggers an overreaction of their immunity, and they end up critically ill from a very mild infection, both because they don't fight the infection properly, and we know the immune suppression, but also from the fact that there's an immune reaction to a minor intrusion. And so, yeah, we're seeing those kind of things happen.
And so when we think about it, because it sounds as though she got not packed cells, but whole blood.
Yes.
Right. Now, one of the things, as have been saying, is that because of what has happened with the vaccination program, it's very unscientific that nobody is interested in antibody levels, meaning that the normal antibody level after an infection is about 300 nanograms per mil. But after vaccination, and especially the booster vaccinations, certainly in the older age groups, you're talking about antibody levels over 6,000 in easily 40 to 50% of the population. And when I say over 6,000, I don't mean 6,000. I mean levels going up to 20, 30,000 in some people. So the question in my mind would be, if you had somebody who had an excessive antibody response and their antibody levels were exceptionally high, and that antibody concentration to the spike protein was infused into someone else, could that cause problems?
Yeah, it would, Philip. It's not being tested for. Compatibility is not checked. We checked ABO. We check for ABO compatibility. We check for RH compatibility of blood. So we make sure that there's the least possibility of cross-reactivity. But we're not checking to see the level of antibodies to spike protein in the blood that we're transfusing. And of course, we're not measuring the levels of spike protein in the recipient's blood in the first place. So yeah, if you've got a high antibody titer and you've got a patient with higher spike protein, you'll produce immune complexes. There's a whole host of things that you could trigger with the antibodies that you're giving to that patient. They didn't come from that patient.
And we also know that there is exosomal circulation of spike protein for long periods of time. I suspect this is what most people are worried about, that they are worried that, if they get a blood transfusion, they could get spike protein, infused into them. But when I pull back from it, whichever way you take it is going to be small amounts. And I'm beginning to think, listening to that history, that a bigger concern would be antibodies because the antibodies would respond to different parts of the spike protein, and you don't know if any of those spike proteins responses are autoantibodies. And so,
Yes.
suddenly, if you had a recipient who had some degree of an autoimmune response after vaccination, and some people don't believe that happens, but I'm telling you it does. The only study done showed a 28% absolute risk in healthcare workers of anti-nuclear antibodies. But anyway, so if they had autoantibodies themselves that were then infused, it's quite possible that that could trigger immune responses in the recipient.
Yes, it is there are autoantibodies that could trigger that response, Philip, but also a wide diversity of other antibody responses.
Hmm.
Spike protein is not really a major issue in transfusion. I'd be cautious in saying that, but from a scientific perspective, spike protein has many cell surface receptors that it binds to. So to find free spikes floating around in your blood is not very easy. It binds very quickly to other cells, other systems. So spike protein levels in your blood, I don't expect to be high, seeing that it is such a receptive substance. So yeah, it is the immunoglobulins or the responses to it that need to be looked into. Uh, we see the effects, Philip. We see the outcomes. We see the unusual injuries and deaths. So it's for the blood services to go back and look at why this is happening. Is it related to levels of spike protein? So find appropriate tests to test levels of spike protein in blood that's donated, immunoglobulin levels, and of course, to correlate, to take relevant data from clinicians that are seeing this and correlate that to spike protein levels, antibody levels, and your ABO system. Is this specific to particular blood group types? Then it allows physicians and surgeons treating to make more appropriate, less risky choices for their patients.
It raises one of the problems that I have with this discussion is that I think that people can get overly anxious about these issues, because
Yeah.
my rule is that you whenever there is risk and in any procedure, you're going from a perspective as to where is the risk the highest. So meaning that if you are bleeding, you can die from bleeding and you need blood, the least of your concerns is
Yeah.
whether or
Yeah.
not there is spike or immunoglobulin or something. If you are quite unwell, because blood is not given just randomly, we don't just give it away.
Yeah.
So within that framework, what who are the people then that it's relevant with?
I think, Philip, when we look at risk benefit, we haven't taken the time to quantify the risk appropriately and to understand why it occurs and to take the appropriate steps to actually decrease or limit that risk. And until we do that, we cannot quantify the benefit. Yes, we can quantify the benefit in someone that has a very high risk from some other issue, like someone bleeding profusely that might need a transfusion. He has a higher risk of death than from the transfusion. But for routine transfusions, there needs to be a recalibration of risk benefit ratio based on spike protein and immunoglobulin levels and compatibility based on other criteria that will decrease the risk in those situations that shouldn't be of any risk to the patient at all. We reached a point where transfusions were relatively safe. So we need to find a way back to that space.
So here's a question. So let's just suppose they did do the research and they found, oh my goodness, there is an issue here, and that the antibodies from certain cohorts, or if somebody had been vaccinated, they are higher risk. There is only a small cohort of unvaccinated. But in any case, how would they prove it? Because you can't prove if somebody says, yeah, I'm unvaccinated. How would you know? Is it that we would just look at spike protein levels in the antibody levels in the blood? What would they be able to do?
Yeah, look, I think, Philip, it's to quantify those things. We're having problems around the world uh, in spike protein staining, in looking at histology to figure out how it biodistributes, to look at its levels, quantify its levels in the blood, to look at the immunoglobulins produced, all those kind of things. So we need new testing to be put into place so that we can understand the new pathologies that we see. And until those new tests are put into place, we're never going to understand or not understand, but never mitigate the risk that blood transfusions pose. And remember, this risk will also surface with organ transplantation because spike
Mm.
protein permeates organs as well. So, yes, if we find that there is a problem, that when we take blood from unvaccinated patients, there is the risk of there being spike protein, then we need to screen for it. Because there is, I'm sure, a large cohort of vaccinated patients who don't make spike protein. We've
Mm.
seen that. And so they can be classified unvaccinated as far as donors go. If we understood what donation was, what risky, the risks were of donation. But
This is what the
if we
this is
don't
what the
look,
paper said, just as you said. One, you identify the risks, medical interviews, blood tests. You assess the risks, which is reviews and meta-analysis and storage and so on, following up what happens to patients. Then you try and control the risks, you mitigate it, decontamination of blood products, and then you train and review it, and then you go back through the cycle again. This would be such a massive I'm trying to find the word for the scientific community to do that would in effect almost put them at risk of litigation. I don't think they would ever do that.
Philip, it's not whether they will or not. It has to get done. We can't stand by and watch this happen. We're a scientific community. At the end of the day, it will divide us. There are those of us who will go the extra mile to try and find solutions to this. Remember, at the start of the pandemic, Philip, when I recognized that it was an immunologic response to spike protein, I approached labs to try and develop a spike specific IgE test to see who's at risk in the first place so we know who to isolate. And I found that almost impossible to do because it went against the narrative, and it would isolate, or it would make certain part of the population uh, not or unnecessarily vaccinated because they don't have IgE or won't produce IgE levels. They're not allergic to spike protein. They'll have no effect from it. So yeah, I think we need to have a relook at the entirety of what's happened and understand that it has had a profound influence on human physiology and pathophysiology. And if we want to remain true healthcare practitioners, then I guess patients are going to gravitate to those who solve their problems and take the time to understand the problems.
So
So I think becoming obsolete will solve the problem. We
so
don't have.
as we close out this short session, Shankara, it then still comes back to the question. So the person comes to you and they say, I am concerned about risks with blood transfusions. What do you say?
Look, I'll have to advise them accordingly, meaning if it is a serious risk, the risk being the injury inflicted that requires the blood transfusion. And if that risk was very great, means posed a threat to your survival, then by all means have the blood transfusion because we don't have the means now to actually ensure that it's actually safe. But if you needed a blood transfusion for a uh, elective procedure, then you should be allowed the choice to get an unvaccinated donor with the same blood group as you to ensure that you've got blood that was risk free until the blood services catch up and can provide you with the same risk free blood. because we know there's a risk.
Yeah, this is important stuff. Yes, so as usual, we're tackling some complex stuff, Shankara, and as usual, Shankara deals with it as gently as he can.
Yeah.
But it does raise a lot of questions. A lot of people are concerned about it. My takeaway would be as we close out, and for every decision in medicine is a risk benefit decision. You have to assess whether or not that concern that you have is justified based on the risk that you're facing with needing the blood. Somebody's very anemic, say they had chemotherapy, they dropped their hemoglobin all the way down to 3 or 4, and they need blood. Maybe they minimize the amount that they have. Instead of having 4 units, they have two. I don't know. But what I'm saying is that if you need it, there's no point worrying about a risk that we can't yet quantify, but certainly requires some pressure on regulators and systems to do the necessary research. So, thank you all very much. And again, just a reminder that if you want to join the membership on YouTube Vision Health, please do so and look in the description for other links. And I'm sure we'll be talking with Dr. Shetty again soon about more clinical ideas, and he'll hang with me for a few minutes. Okay, have a good evening, everyone.
Thanks for that. Thank you.